Assalamu alaikum. Today we are discussing a right-sided nephrectomy for a non-functioning kidney in a 17 years old girl with a very small stature and a very small abdomen. It is just like performing nephrectomy in a pediatric patient. So the pneumoperitoneum was created and the pressure was kept around 10. So we went in, we saw the adhesions. There has been a lot of inflammation and recurrent pyelonephritis over the time. So there is adhesions to the surrounding structures. So first of all, we are here to mobilize the liver from the kidney and then decide whether we have to use a liver retraction or not. So after mobilizing it, we are now comfortable, and we can see that in a while we'll see that liver retraction is not really required. Here the duodenum is exposed and we can see the line of the inferior vena cava alongside the upper pole of the kidney. But the rest of the structures are not as clearly visible as in other cases. So we'll be doing it in a very slow fashion, identifying the structures, and only then we will cut any structure if they are in the way. So here we assume that this might be the inferior vena cava, which is covered by a lot of adhesive tissue. So the first step in the right-sided nephrectomy is to identify the ureter. As I mentioned earlier, that there has been a lot of inflammation in the kidney previously. So that's why the structures are really very difficult to identify. And we are doing this in order to avoid any injury to the inferior vena cava and the gonadal vein, especially because we cannot clearly see where the gonadal vein is. Here is a structure. Most likely this is excuse me. Most likely this is the ureter. So we are making a window between the ureter and the inferior vena cava, and we'll be happy when we see the psoas muscle. So you can see a very thick layer of connective tissue and supportive tissue around the ureter. So this is the ureter which is being dissected. The abdomen is so small that the telescope is lying just over the organ. So when we are using the ligashore or the diathermy, the smoke is coming directly onto the lens. So we have to go back in order to preserve good vision. Here you can see the purpose of sharing this video is that we can see that it's the ureter superiorly. Here you can see this is the ureter, but there is another structure which is coming from the kidney or to the kidney. It is very thick walled. So we thought it might be a vein, or we also thought of it to be the ureter, a second ureter, that this might be the kidney with a duplex system. So we reviewed the CT scan again, but we couldn't find any duplex system. But the structure is really thick walled and it is separate from the ureter, and we can now clearly see the psoas muscle. So we keep on dissecting. So after identifying the ureter and the psoas muscle, we are now confident enough to dissect in the line of the ureter so that we can reach the hilum. and the liver has dropped down, so there is no need for the liver retractor, and we performed this surgery on 4 ports. Otherwise, generally 5 ports are required in the right-sided nephrectomy because the liver has to be retracted by 1 port. Here some structure opened because we don't know where the structures are. We thought this might be the gonadal vein or it might be the adrenal which is bleeding. However, after trying to control this bleed, we came to know that the hemostasis has been achieved by the ligashore, so there might be a small vein or something. However, the ligashore was able to coagulate this structure, and hence we dissect this area with real cautions, because if this is the hilum, the artery may be nearby. So, reducing our speed of dissection is the key, and keep the field clean. If the field becomes red, it's really difficult to identify structures in an already difficult to identify anatomy. So there is a tubular structure which most probably is the renal artery, or it might be a renal vein, or it might be both the renal vein and the renal artery, which are closely plugged to each other because of the inflammation. However, it is very much clear that this is some tubular structure which is including the vein, but the artery may be inside this structure. So we dissect it above and below, and instead of dissecting them separately from each other, we decided not to separately dissect them, and we will, because the structures are small, so the hemolock clip can control both of them. So by dissecting further along the line of the inferior vena cava, we found the gonadal vein, which was really difficult to identify lower down. It might also be extremely adherent to the ureter. However, we can now see that the gonadal is, since this is a small vein and it is then running alongside the border of the lower pole of the kidney, so we take it as the gonadal vein. It is difficult to separate it and dissect it from the kidney, so we clip this gonadal vein instead of avulsing it from the inferior vena cava. In the process of dissection, we decided to just dissect it enough so that a clip can be applied. So this further opens way to dissect the kidney from the midline. And moving towards the hilum, we find another structure, which is tubular structure, very small, and it is pulsating as well. So this might be one of the arteries. So clipping this structure is a wise decision. So we clip it with a 5mm hemolock clip, and then we seal it with the ligashore, and then we divide it. And then comes some more structure, and it is also a very tubular kind of structure. Seems to be a renal vein. So we have a plan to clip both these structures, the previous one which was dissected and this one as well, so that a perfect hemostasis has been achieved. And now we can use a right angle, a 10 millimeter right angle, which can dissect between the two structures and make a space for the hemolog clip to be applied easily. So we find a window and we enlarge this window with a 10 millimeter right angle. So this is perfect. And now the second structure, which may be a vein or maybe an artery and a vein, or it may be just an artery which seems a little bigger because of the inflammation around it. So one clip is applied and the other one clip is applied on the other structure. So a second clip is applied on the other structure. These clips are 10 millimeter hemolog clips. So another clip is applied, and then this inferior structure is sealed with the ligature. And then the third clip is applied and the structure is divided between the clips, and we find that this is an artery, or this might be an artery as well as the vein. So then comes the dissection of the upper pole. So releasing the kidney from the upper pole. We have a plan for the other structure, which is lower down along with the ureter. So we will be dissecting that structure to know what that structure really is. Is it a vein or is it something else? Why is it coming to the kidney? So dissection of the upper pole is complete, and now we are mobilizing the kidney from the lateral border. Once the whole kidney is mobilized from all around, the other structure will be dissected and dealt with. Okay, so the ureter is exposed even more. So the structure is exposed even more. We can see a vascular structure going in this structure, which is having a Y-shaped configuration. There are two limbs towards the midline, whereas there is a bigger stump towards the kidney, and that stump is actually fused with the lower pole of the kidney. I also had a doubt that this might be a horseshoe kidney. However, after reviewing the CT scan again and again during the procedure, we found that it's not an horseshoe kidney, because in horseshoe kidney the isthmus may be fibrotic, and this fibrosis usually varies. It can be a very small 1 centimeter structure and can be a longer structure as well. So here you can see that the ureter is completely separate from that structure. So we decide to disconnect the kidney along the ureter and then find out what it is. It really surprises me. If you have any expert opinion on that, you can comment on it. Here you can see it is fusing with the lower pole of the kidney. That's why I doubted that this might be a horseshoe kidney with a long isthmus. However, while dissecting this limb, we found that there are two vascular structures which are fusing together as they go towards the kidney. However, one of the structures is actually pulsating. This one that we are dissecting now is a non-pulsating structure, so we take it as a vein, and And the other one is, this one is actually a pulsating structure. So this is an artery. So it's a very strange variation of the vascular pedicle. Here you can see pulsations. And it is not the left side, mind you, that this may be a transmitted pulsation. This is an actual and real pulsation. Here the structure or the architecture or the texture of this structure is that of an artery, but this one seems to be a vein. So let's dissect and see. So in the end, we have decided that we will clip this each tubular structure individually and separately, and then we will disconnect it from the kidney so that the nephrectomy is completed. A very surprising anatomy that I have seen for the first time. So I'm using a 10 millimeter clip for this because it seems to be an artery, so has got stronger pulsations, so a stronger hemolog clip is used. We use another one and another one on the other side, and then we use the ligashore distally in order to complete the procedure. Thank you very much for watching. I hope you have enjoyed it, and any expert comments, please comment on the video. Thank you very much.